Our next paper is going to be titled Residents' Participation in Laparoscopic Roux Gastric Bypass, a comparison of outcome from the ACS NSQIP database. The paper is going to be presented by Dr. Doyon from Lehigh Clinic and Tufts University School of Medicine.
I'd like to thank the SAGES Committee for having an opportunity to present this paper. I have no disclosures, although my fellowship is partially funded by the Foundation for Surgical Fellowships, which I appreciate. The background is that there's been an increasing trend over the last decade that hospital reimbursement and patient referral patterns have been increasingly dependent and tied to publicly available outcomes data. Additionally, recent literature has suggested that teaching hospitals or resident involvement in complex laparoscopic cases may be associated with worse patient outcomes. And so there's a difficult balance in optimizing patient care and for the hospital reimbursement versus resident training. So what we wanted to know, especially in light of the, maybe I could say, scathing review of resident ability by the American Board of Surgeon lecture by Dr. Lewis today, does resident involvement in complex laparoscopic cases, namely laparoscopic gastric bypass surgery, affect outcomes negatively? The most recently published data on this topic, and also the largest data set, comes from Krell and Birkmeyer in 2014, using the Michigan Bariatric Surgery Collaborative from 2006 to 2012, where they took 17,000 patients that underwent laparoscopic Roux-En-Y gastric bypass. What they found is that overall there was a greater incidence of complications in the resident group. Specifically, operative time was increased by 41 minutes. Wound infections, both deep and superficial, were increased in the resident group, 4.5% versus 2.3% in the attending group. And additionally, resident participation was an independent predictor for venous thromboembolism. So the group concluded that residents contributed negatively to outcomes of bariatric patients, and that residents ought to undergo increased training outside of the operating room to help compensate for this. So for our study, we queried the participant use files of the NSQIP database from 2005 to 2012. We chose CPT codes for laparoscopic gastric bypass, and we separated the groups into resident versus attending alone cases, and we analyzed patient characteristics, perioperative data, and 30-day outcome. So there was a total of 43,477 cases available for analysis, and they were split fairly evenly between the resident and attending alone cases. And the two groups were comparable. The average patient had a BMI of 47 and was a female Caucasian, age 45. Main comorbidity was hypertension requiring medications present in over 50% of patients, followed by diabetes in about a third of patients. And on multivariate analysis, we found that, yes, there were some statistically significant worse outcomes in the resident participation group. However, the overall incidence of all complications was still low. So for instance, in the superficial site infection, there was an increased incident in the resident group, labeled R, of 2.1% versus in the non-resident group of 1.5% for an odds ratio of 1.47. You can see in the following complications, renal insufficiency, urinary tract infection, sepsis, and readmission, that the differences in the incidence are even smaller, yet due to or rather as a function of the large data set of the NSQIP database, these become significantly significant. Additionally, operative time was increased in the resident group by about a half an hour, and kind of unsurprisingly, with increasing seniority of the resident or the trainee, there was increased time taken for each operation. Importantly, there was no clinical difference in the following outcomes: length of stay, pulmonary embolism, organ space infection, which in the NSQIP database is probably the closest proxy for a leak, return to the operating room, and mortality. So in conclusion, there were some statistically significant differences in complications in the resident group. And for example, probably the most significant difference in incidence was that of increased superficial site infection. However, it's unclear how clinically meaningful this is since it's such a small increase in the incidence. And renal failure, sepsis, urinary tract infection additionally were statistically different but not clinically significant. There was a higher readmission rate in the resident group, but there was no difference in mortality, venous thromboembolism, leak, or return to the operating room. So as a final conclusion, the increased operative time spent in teaching residents gastric bypass is not associated with a significant increase in complications. Thank you.
This paper is open for discussion.
So I have a couple questions for you. So is this a teaching hospital phenomenon? Is this a resident phenomenon? Meaning that if you had a group of non-resident, non-fellow bariatric surgical outcomes, then you had one with fellow, kind of like we had presented earlier, and now you had this one.
Yeah.
You may get a little bit more clarity on whether it's the teaching hospital versus resident versus fellow.
Right.
The other is, and I'll kind of just throw this out, in a study like this, you can't really tell what the talent and skill level of the attending is. And the reason I say that is I've seen it at places I've been where the attendings aren't as skillful as the attendings are in other locations, meaning the resident actually augments the technical ability of the attending. And so, you know, what do you think about that in terms of what your outcomes are?
Right. To answer your first question about the teaching environment, I think is maybe what you're getting at, more so than the resident as being the operator. It's definitely been suggested before in prior studies that a resident participation is a good proxy for a teaching environment. And maybe, you know, the person, say, closing the incisions is the junior most person in the room, and that might be a student. And maybe, you know, a student or a visitor is putting in the Foley catheter. So absolutely, it could be not so much a function of the fellow or resident operating, but more so a function of the teaching team and the other learners in the hospital. And to answer your second question, I think that most pairs of attending and learner typically will let the learner do what they can in terms of what's safe, and maybe the attending realizes that the resident should be doing more of the procedure. And I assume that that judgment probably carries through nationally. Yep.
Thanks.
I have a question. I think I think the study is assuming that if the resident is not in the operating room, then therefore they're not also taking care of patients afterwards, meaning that it's a non-teaching hospital. From the results of the study, does this mean that really what educators should be focusing on is post-op or education of residents on post-op care, since all the significance were on post-op complications as opposed to intra-op complications?
Like the...
such as like the DVTs, the UTIs, the sepsis,
Sure.
readmissions, those are not
Right.
intra-op complications.
I think you have to kind of break those down individually. So readmission, I think, is probably a function that a teaching hospital doesn't have a centralized office that the attending can be reached in, say, a private surgical office setting, and so the patient comes to the emergency room and gets readmitted, rather than maybe taking care of things in an outpatient manner. So that might be one explanation for that. Additionally, for the other complications, such as venous thromboembolism you brought up, for example, in the Michigan study, and maybe this has changed with the greater use of SQIP measures, but they were found to have the resident groups were less likely to actually have appropriate venous thromboembolism prophylaxis. So that might be an educational thing that needs to be addressed. Absolutely.
Thank you.
Okay, thank you.